So my name is Daniel Klink. I'm a pediatric endocrinologist from the Paola's Children's Hospital, and I will give you a presentation on growth, and it's called short stature from clinical presentation to a diagnosis. So the learning objectives of this talk would be, you know, the screening criteria for short stature, you know a bit about differential diagnosis, and hopefully I'll be able to provide a practical approach towards a patient with short stature. So first, if you look at, there's a definition problem, because what is short stature? When is someone too short? We all know that height has a normal distribution, so there's a variation within the population, and it's normally distributed, so it's a Gauss curve. But the problem is with pathological short stature, there's a certain overlap. Yeah, there are patients without the disease, the healthy population, and there's a population with the disease, the pathological population. But as you can see, there's always a small overlap. So to make sure you don't want to miss anything, we decided actually when is someone too short, it's someone whose height is under the -2 SD. And I would like to stress out that the present height is -2 SD, but also, as you can see on this slide, there's also of the appropriate reference population. Because as you can see, this is a pygmy population, and it's a British colonist, I assume. There's a height difference, of course. So you need to have the appropriate reference population to define when someone is too short or not. So what kind of reference populations do we have in Belgium? I work in the Flanders, in Vlaanderen, so in the Flemish part of Belgium, and we use the Flemish growth charts. They were established in 2004. It was a cross-sectional study of roughly 8,000 Flemish boys and 8,000 Flemish girls. And this reference population is appropriate for children who has like one Flemish father or mother, one parent of Flemish descent, and one parent from Belgium, regardless their background. But also, there can be a parent from several other countries, and you can list them here. So it's the Netherlands, Germany, Luxembourg, France, England, Denmark, Ireland, Norway, Sweden, Austria. Bit hard to remember, I think, and I always thought, what's the common trait of these people? And then I found out, actually, they're all winners of the Eurovision Song Festival. So if you're in doubt whether it's the reference population is appropriate, just ask if the other parent, did your country win the Eurovision Song Festival at one point? If they say yes, probably you can use this reference population. But what about the rest of the inhabitants of Belgium? Because, you know, it's only Flanders and a certain Northern European region. So the BESPEED recommendation is actually to use the WHO chart. And the most recent one is the one in 2007, published by the Onis et al. And actually, they use it's a bit statistical talk, but they use this old reference charts from the 1970s, and then they merged it with other data from 2005, and that's the Cole charts from the age of 0 to 5 years, and that was like 12,000 healthy infants and children. They were partly longitudinal, so they followed up children from the birth till the age of 24 months. There were also cross-sectional studies, and I think it was the key selection criteria was that they were healthy newborns, healthy children. There were no socioeconomic constraints on growth, so they were affluent offspring. And also, the mothers had to be non-smoking, and they were breastfeeding the infants they were born at term. So So for the rest of the Belgium, we recommend to use a WHO chart from the age of 5 to 19, the 207, and from the age 0 to 5, 206. So that's one selection criteria. And then we all know it runs in a family. There is a genetic component, of course, and we all know there is a target height. So what is target height? Actually, target height is defined as a more mathematical approach also for mid-parental height. So we take the height of the father, the height of the mother, and then we divide it by 2. And then we add a number, 6.5, for to correct for the sex difference for your final height. And for a girl, you subtract for 6.5 centimeters. But of course, there's, as you see by the picture on the left, the bullet, there's a target, but you don't always hit the target. There is a range. So we work with target height range. And as you can see, that's a big range, actually, because the target height range in children or in boys is plus or minus 10 centimeters. So that means that a family can have 2 children, 2 boys, and their final height could be 20 centimeters apart. So that's always good to know when you're counseling patients or parents in there, when you have them in your consultation room. And for girls, it's a little bit smaller. It's plus or minus 9 centimeters. And actually, 95% of the children fall within that target height range. So in case your height is under your target height range, there is some follow-up indicated. But it's all relatives. But as you can see, there are some drawbacks to this height calculation, which is already postponed in 97 by Thanner. It only explains 25 variants in the attained height. And it's also inaccurate when there's extreme heights of parents. So we all know from daily practice, if the father is 190 and the mother is 160, you can throw your target height calculation out of the window because it's not useless. And actually, I think it's very illuminating that already in 1886, Dr. Galton reported on that phenomenon. There's a regression to the mean. So we have 2 extremes. Nature tends to go back to the mean. When you so that's the large difference between the parental heights, and it doesn't compensate for secular trend. Secular trend means that every generation, gets a bit taller by the era. So it doesn't calculate or doesn't compensate for that also. So there are some relatively drawbacks on the current target height calculation and the target height range we use at this point. So we have now also defined already 2 screening criteria. So when is someone too short? Your present height is under the -2 SD of the appropriate reference population, or your present height is under the target height range. And there's another criteria, which we also encounter in our daily practice: not growing well. That's a very difficult term, and that's also when is someone not growing well, because height or height attainment is not a static given. It's fluids it changes throughout the time, because you can see that even from birth, when the height STI is high, when someone is born large for gestational age, they also can drop to another STS when the target height STS is much lower than the initial birth length. Also, what we do know that between the age 3 to 10 years, the height STS, the growth velocity, is usually stable, and also a deflection of more than 0.5 SD is unusual. But then if you go into the late teens or the early teens for boys, we all know that they start to grow slower. They have their known prepubertal dip, as you can see here, prior to that growth spurt. So the definition of not growing well is very complex. It depends on what the situation, what the present condition or lifespan the patient is. So the BESPEED really thought hard about that, and we had numerous discussions on this one. But our recommendation is that like a height deflection more than 1 SD over a period of 12 months is a reason for further investigations. However, there are some other authorities that use a bit different guidelines. As you see that in the public health services in Flanders, they will refer to a specialized growth center when the decrease in height is more than 1 SDS over the past 3 years. And also because it was the statement or the recommendations made by pediatric endocrinologists, we do feel we get not the first patient, but we get more referred patients. So in this, in that 12-month period may be too long in some cases. So we left that up to the actually to the clinician whether to start investigations or not. So what's the differential diagnosis? Basically, it's not that hard. There are two groups. First, you have the primary growth disorders, and those are actually the skeletal tissue and connective tissue disorders, the genetic diseases as hypochondroplasia, as you see here, Turner's syndrome, and then we have actually the secondary growth disorders, and those are actually all the diseases, all disorders which are outside of the skeletal system. And how can you differentiate between these two? It's very important to look at body proportions. So it's when you examine a child, it's important to address sitting height. You measure the sitting height, and then if you want to have the index, you divide it by the height. And you can also do it for the arm span, the arm's length, the arm span index. Those are two big or important clues in your differential diagnosis. So that brings you also a bit to the difficulty of your practical clinical situation, because either your differential diagnosis depends on your body proportions, what route do you have to go. But generally, when someone enters your consultation box, you start with the history taking, and then you do the physical examination. So for the sake of time, I'll just do it more in a more conventional way. So you go for a extensive history taking. So what are the complaints? There are general complaints, fatigue, anorexia. How's the miction? How's the defecation? Is there polydipsia? Are there abdominal complaints? But also the previous history and the family history is important. So what is the grandparental height? So not only the height of the parents, but the height of the grandparents. What's the onset of puberty of the parents or siblings? Perinatal history, was the child born small for gestational age or not, or even large for gestational age with short parents. How is the nutrition and weight development? Are there any, how's the psychomotoric and psychosocial development? Are there signs for emotional stress, emotional deprivation? And also, are there any underlying diseases or previous surgery or trauma? So that's your history taking. And then for the physical examination, it's of course important to do the height and weight. Also to look at the proportions. So you need the head circumference, the sitting height, the arm span. Pubertal state is also important. Are there any dysmorphisms? Can you palpate the thyroid? How is the fat distribution? If you look for systemic diseases, is there organomegaly? So if you look in a very simplified flowchart, you have short stature, and I already defined that. You have two big categories of disorders: the primary disorders, the secondary disorders. The primary disorders can be done, you can divide in the disproportionals and the proportional. And I think it's really important, and Carl will allude to that, to look if there's the children with the physics in the SHOX gene. That could be the SHOX itself or Turner syndrome. And to simplify things a bit, I said secondaries would be endocrine and non-endocrine. So we do have a recommendation for initial screening to see if we can find a cause for the short stature. So also first we do bone age, so you can determine the growth potential. Is it delayed? Is it advanced? Or is it just right? For the endocrine parameters, we recommend to do IGF-1, thyroid function. Intestinal parameters would be to rule out celiac disease, and also when the child is older than 10 years old and the BMI is decreasing, we recommend to do a blood count, and also, I think most important, the fecal calprotectin to exclude inflammatory bowel disease. Anemia can also induce poor growth, so we recommend to do a blood count also, or the renal functions can lead to growth failure, and also in very rare cases bone metabolism. And it's always important to look at the genetics also. In girls, we recommend to do a karyotype to exclude Turner syndrome. And when you have disproportional axiology, you can either do a SOX sequence, a gene panel for short stature, or gene panel skelet dysplasia. But I would recommend that only to specialized centers to do. So I want to talk a little bit on IGF-1 because it's an endocrine presentation theme, and I do not want to talk about growth hormone deficiency per se for this talk, but more in the disturbances of the growth hormone releasing hormone, growth hormone, IGF-1 axis. So actually there can be a disturbance in all three of them. And as you can see, I think it's a very nice graph or figure made by Professor Savage. He's one of the, founding fathers, I guess, for growth failure. There is a spectrum of growth hormone deficiency, growth hormone resistance, and there is that idiopathic short stature. And as you can see, there's an overlap, and I think it's very difficult task to discriminate when is someone true growth hormone deficient and when is it just idiopathic short stature. And this slide also illustrates it a bit, but refer to height, SDS, and IGF values. You can see how taller, how shorter you are, the bigger the chance on pathology is. So if you look at the true growth hormone deficient patients, there is also, for instance, you have Prader-Willi syndrome, which is associated with growth hormone deficiency, but also with growth hormone secretion abnormalities. And if you look in the other spectrum of growth hormone resistance, we have the Noonan syndrome and also renal insufficiency. So I did not mention those by chance because these are the categories that Carl will address because we do have therapeutic options for these categories. So to conclude my presentation, I hope I was able to give you these three learning objects. So what are screening criteria for short stature? What is the differential diagnosis? And also, hopefully I was able to provide a practical approach towards short stature. So, bedankt voor de tijd. Merci de voor het attention.